Hi, everyone. Thank you for joining us. Welcome to Sexual and Reproductive Health in the Era of CFTR Modulators at ResearchCon. My name is Megan Lepore. I am an adult with CF. I'm 35. I'm a mother, and I'm excited to be here. I live in Silver Spring, Maryland. I'm going to be moderating tonight's session and introducing our other speakers in just a moment. Before we get started, I wanted to go over a few housekeeping items related to technology and how we can all interact. We'll be taking audience questions during this session, so if you have any questions, you can submit them at any time by clicking the icon on the right side of your screen labeled Q&A, as you can see in the slide up here. You can also see other questions there and give a thumbs up if you want that question to be answered. So, when we ask that when you think about your question that you please formulate in a way that can be helpful to everyone here. We won't be able to answer individual questions, give individual diagnoses. So we encourage you to use the information you learned today to have conversations with your care team moving forward. And we will do our best to answer as many questions as possible. You'll also notice a chat bubble on the right side of your screen. You may be already seeing the event chat come in, and that's for everyone in the session to talk with each other as you go along. You can view it or hide it as your preference. If you have questions for the speakers, use the Q&A icon to submit it, and we will get to those at the end. If you have any technology problems, please go to the Tech and Program Support Room on the home screen of the event, and that's the icon that looks like a lab. So finally, I just want to say that we do have a poll, so please, we invite you to use the poll to let us know what your connection to CF is today. So at this point, I'm just going to quickly introduce our other panelists, Jillian Mosek, who is an adult with CF and a mother as well, and Dr. Jennifer Taylor-Cousar, who is going to do our first presentation of the evening to kick us off. I'm going to turn it over to Jennifer.
Great. Thanks, Megan. So I am Jennifer Taylor-Cousar, and I'm the co-director of the adult program at National Jewish Health in Denver, where I'm also director of the Therapeutics Development Center. And these are my disclosures. Most of them are related to the fact that I'm the primary investigator on many of our studies, and also because I do some consulting work to help people design clinical trials. So our objectives this evening are to review the impact of cystic fibrosis transmembrane conductance regulator, or CFTR modulators, on contraceptive methods, also to understand the potential impact of highly effective modulator therapy on fertility in women with CF and in men with CF, and finally to describe the potential risk and benefits of the use of CFTR modulators during conception, pregnancy, and lactation. So let's start by talking about fertility in women with CF. So women with CF generally have reproductive anatomy that's similar to that of women without CF. However, there are some factors that can affect fertility. First, the thick, dehydrated, pH imbalanced cervical mucus. So the cervical mucus is more acidic than it should be, and that makes it difficult for sperm to penetrate the eggs. Some women with CF also have delayed puberty and ovulation, and then some women have suboptimal nutritional status. However, the majority of the women who want to have babies who have CF can do so. There was a study recently by Steinberg and colleagues that reported a 35% subfertility rate, so women who weren't able to get pregnant. The risk factors that she associated with that were pancreatic insufficiency and older age at first attempt, as the same as in women without CF. Importantly, and I think this is because there is a myth amongst some that women with CF can't get pregnant, they reported that 25 to 49% of pregnancies in women with CF are unplanned. Now, what about in men with CF? It's different. So 97 to 98% of men with CF are infertile as a result of congenital bilateral absence of the vas deferens, or CBAVD. So what does all that mean? So I've shown you two pictures here. One is in the body and one is freestanding. Normally, sperm are made in the testes and stored in the epididymis. Then they travel up the vas deferens and come through seminal vesicles and through the prostate and out through the urethra. The problem for men with CF is that they are born with the absence of these tubes. So men with CF make sperm and can store them, but they can't get them to where they're supposed to go. And that's why it's called obstructive azoospermia. So the sperm are here and they don't appear in the semen. Now, what do we know about the impact of modulators on genotoxicity, so the development and everything of the fetus, and fertility? So each of these drugs, ivacaftor, which is Kalydeco, lumacaftor, which is part of Orkambi, lumacaftor, ivacaftor, tezacaftor, which is part of Symdeko, and alexacaftor, which is part of Trikafta, we know that when those are tested individually, there isn't an impact on the chromosome of the fetus. Now, if you look at fertility in animals, you can see that there was no effect on fertility for lumacaftor or for tezacaftor. But for ivacaftor and alexacaftor, when the mom rats and rabbits were given toxic doses of the drug, ivacaftor or alexacaftor, there was an effect on fertility, but only if they were given toxic doses. Now, what about in people? We actually believe that in women with CF, highly effective modulator therapy may actually increase fertility. Now, how would it do that? One way it could do it is by improving general health and nutrition. But the more likely way is probably because it decreases the thickness of the cervical mucus and it improves the pH so it's less acidic, and that makes it easier for the sperm to penetrate the egg. Now, what is the evidence for this? First, in the studies of Kalydeco in women with CF and G551D, about 2% of the women in the trial actually became pregnant, even though they were supposed to be using contraception. Also, there are several case reports in the medical literature of women who unintendedly got pregnant while they were on Kalydeco. There was also a survey of about 500 mothers across Europe and the UK, and they asked them about pregnancy and fertility. 12 of them reported that they were infertile, so they had tried for at least a year to get pregnant and were unable to do so. However, after starting Kalydeco, 7 of those women became pregnant, and they did so within an average of 3 months after starting Kalydeco. So it's that evidence that makes us think that maybe highly effective modulators cause women to be more fertile. Now, what about men? So we know from data way back in the 1960s that men with CF have a smaller volume of ejaculate than men without CF. And why is that? So I told you that men with CF don't have the tubes to get the semen, the sperm into the semen. But mostly, if you look on the right, you can see the composition of semen and seminal fluid. Almost all of it in men with CF comes from the prostate because they don't get the semen coming through all of the tubes that are supposed to be there but are absent. So we think that because a lot of the fluid in men with CF comes from the prostate, when starting a highly effective modulator, the volume of the seminal fluid may increase. And it's not because there are now sperm in that fluid or the tubes are now there. It's because a lot of that came from the prostate, and there are actually CFTR channels in the prostate. So again, some men may have a higher volume of ejaculate. We have heard anecdotally that some men do have testicular pain after starting Trikafta. So a question that frequently comes up is, can infertility be rescued in men with CF? And we think at this point the answer is probably no. So why do we say that? First, there are some men with 2 CF mutations in their genes who are infertile. That's the only sign they have of having a problem with their CFTR gene. And in fact, there are some men who have a single mutation in their CFTR gene and no other signs or symptoms of CF who are also infertile. So that tells us that it's very, very sensitive. While the baby is developing in the womb, they must need a lot of CFTR function, near normal or completely normal, to have the vas deferens form. The other evidence comes from animal models. So many of you will have heard about the CF mouse and the CF pig, but they also have CF ferrets. And the group in Iowa actually gave pregnant CF ferrets Kalydeco while they were pregnant. And what they saw was that if the animals had 2 copies of G551D, which we know is very responsive to Kalydeco, then they could rescue the vas deferens in those babies. But if they only had 1 copy of G551D, it didn't matter that their mom got Kalydeco while she was pregnant. So it's for that reason that we don't think we can yet rescue fertility in men with CF. So I told you that women are likely to be more fertile on highly effective modulators. So one of the questions is, which contraceptive method is most effective? And do modulators affect these? Which one's safest? We don't really know those answers. But Dr. Emily Godfrey from the University of Washington collaborated with myself and Dr. Raksha Jain at UT Southwestern, and we surveyed 150 women who were aged 18 to 50 and asked them about their contraceptive use. What we found is that women most commonly used combined hormonal contraception like the pill, and then barrier methods like condoms, and then long-acting reversible contraception such as the IUD, and then 24% of them weren't using any protection at all, which again is important if they're going to start on a highly effective modulator, which may make them more fertile. So what do we know from the modulator data about the interactions? Importantly, only Orkambi interacts with hormonal contraception. So Kalydeco, Symdeko, and Trikafta have been tested in drug-drug interaction studies, and they do not interact with hormonal contraception, but Orkambi does. So that means if a woman is on hormonal contraception, such as oral, the pill, injectables like Depo-Provera, transdermals like the patch, and then implantables like Nexplanon, they must use another form of contraception. But again, that's only for Orkambi. There isn't an interaction for Trikafta or for Symdeko or for Kalydeco. Now we talked about the fact that women may be more fertile when they're on highly effective modulators, but what do women think about pregnancy? So several studies have been done. The first one I'm showing you is a retrospective multi-center study that was done in Europe and the UK on 605 women who were over the age of 18, and almost 40% of them had attempted pregnancy. The next study is by Dr. Tracy Kazmersky and colleagues, and she surveyed 188 women here in the US who were aged 15 to 24, and she asked them about sexual and reproductive health, including pregnancy. Almost 80% of these young women said they wanted to have a child at some point. And this last study was done in Australia with a very small group of women who were a little bit older, on average around 32, but more than half of them had already tried to get pregnant, and all 11 said that they wanted children. So women are telling us that they do want to have babies, and what's actually happening. And I show you this slide just from the US, but we know that this phenomenon is happening all over the world. So those of you who haven't seen this before, on the y-axis is the number of pregnancies, and on the x-axis is the year. You can see that back in 1998, there were 140 pregnancies reported in the US patient registry. By 2018, that number had doubled to 280. So women are definitely becoming pregnant more often. One of the questions is about whether or not it's safe to have a baby if you have CF. The first woman in the literature that was reported to have a baby was in 1960. Unfortunately, she died within about 6 weeks of having her baby. So that brought up the question, is it really safe? There were multiple single center studies where they looked back in time and asked, were there factors that made women more at risk if they decided to have a baby? And there were some factors that were shown, such as a low lung function, having burkholderia, having diabetes, all seemed to be risk factors. So the very first time a very large study was done was by Dr. Chris Goss from the University of Washington, and he looked at the registry to get a large number of women to a better perspective. He looked at women from 1985 to 1997, and he found that women with CF who became pregnant were actually healthier at baseline and had better 10-year survival compared to those who didn't. And he did not find any subgroups such as low lung function or different bacteria that made them more at risk. Later on, Dr. Schechter used data from a very large study that was done in the US and in Canada, and he looked at women from 1994 to 2005. He found that women with CF who became pregnant had more illness-related visits, more pulmonary exacerbations, including the need for IVs, and lower quality of life scores. Importantly, he found that women with CF who became pregnant compared to those who did not have accelerated disease progression or increased mortality. And of course, both of these cohorts were done well before modulators were first approved. So that brings us to the question of medication safety in pregnancy and lactation. We always want to balance, when a woman becomes pregnant, the risk to her of stopping a drug versus the risk to her baby of continuing that drug. The Federal Drug Administration, or FDA, previously categorized drugs in the categories of A through D or X, and X meant do not use this drug at all during pregnancy, it's dangerous. But they felt that it was oversimplistic and sometimes overlapping. So after 2015, there was a new rule called the Pregnancy and Lactation Labeling Rule. The goal of this new rule was to provide clinicians with relevant information so they could tell women with CF or without how to make these really difficult decisions about continuing or stopping drugs when they were pregnant and lactating. The requirements are that they have to state whether or not there are adequate and well-controlled studies in pregnant women to say if there's a drug-associated risk with major birth defects or with miscarriage. Also, in the animal studies that they're required to do, the sponsor, or in other words, the drug company, has to say how much drug was given to the animal compared to the maximum recommended human dose and what happened to the fetus as a result of that dose. So let's look at the animal data for modulators. So if you look at ivacaftor, when they gave toxic doses to the moms, both in rats and rabbits, there were no effects. And the same was true for lumacaftor. For tezacaftor, there was no effects of giving the mom a toxic dose in rats, but in rabbits, they saw a little bit of decreased body weight and some problems with the eyelids and where the ear connects. For elexacaftor, in rats, they saw decreased body weight at toxic doses to the mom, but it was fine in rabbits. So the data was a little bit mixed. But again, all of these were tested individually, not in combination. And we're talking about giving toxic doses to the mom, not normal doses. But the issue has been that we don't really have a lot of data in women. So there have been some case reports of Kalydeco and of Orkambi in the literature that showed it was probably safe, but there are very few reports. So myself and Dr. Ed Nash, who's from the UK, and Dr. Peter Middleton, who's from Australia, decided to survey CF clinicians and ask them about women who chose to stay on modulators or accidentally were exposed to modulators during pregnancy and lactation. So we gave a 2-page survey for Kalydeco, for Orkambi, and for Symdeko because Trikafta wasn't yet approved. What we found are these baseline demographics, meaning the characteristics of the women who were in the study. So there were 31 who were on Kalydeco, 26 who were on Orkambi, and then 7 who were on Symdeko. Their average age was around 25 to 30. Lung function was lower in those on Orkambi and Symdeko, as you might expect, because some of the women with on Kalydeco would have more mild mutations. And everyone's BMI was pretty good. This graph actually shows the percentage of women who were exposed to modulator during pregnancy on the y-axis. Along the x-axis is a different trimester, and then the different colors represent the different drugs. So you can see that women were exposed to all of these different modulators in at least one trimester, if not all the trimester. So what did we find out? So the use of CFTR modulators during part or all of pregnancy only resulted in 2 maternal complications that the doctors thought were related to being on modulators. One was a pulmonary exacerbation on Orkambi, and the other one was a blood cancer, which actually hasn't been reported in any other case of Orkambi, so we're not sure if that was really related. Importantly, the miscarriage rate in our study was only 4.7%. I say only because on the average in the population without CF, it's 10 to 15%, so that was actually quite low. Another really important point, and I said there was a balance between leaving somebody on a drug and their health and the baby's health. We found 9 women who had decline, 7 in their lung function, and 2 developed pancreatitis when they stopped their modulator they had to restart it. And then for the babies, there were no modulator-related complications for any of the infants that were exposed while the mom was pregnant. So the next question is about lactation. So again, I've shown you the different drugs along the top. In animals, we know, based on the animal model, that there is ivacaftor, lumacaftor, tezacaftor, and elexacaftor in breast milk. The other thing that's important is that when Kalydeco was given to baby rats, those baby rats actually developed cataracts. There is a warning label that says that kids who are on Kalydeco have to have their eyes checked. So that's something that we wanted to watch out for. We did have one case that was reported in the literature where a woman stayed on Orkambi. She actually stopped temporarily and then her lung function went down and she went back on it, but she breastfed while she was on Orkambi. And so the researchers at UNC measured lumacaftor and ivacaftor in the breast milk and found both of them to be present. But again, no large studies. In our study, we had 27 women who continued to breastfeed while they were on their modulator. And we found that none of the infants had cataracts, although only 4 had formal testing. None of the moms reported vision problems for those babies. So in conclusion, of the approved modulators, only Orkambi interacts with hormonal contraception. Women with CF have reproductive anatomy that's very similar to that of women without CF, but the majority of men with CF are infertile because of lack of the vas deferens with which they're born. The number of women with CF who want to have pregnancy is increasing, as are the numbers of women who are actually having babies. The use of CFTR modulators likely increases fertility in women with CF, but there isn't an effect, we think, on men with CF. And finally, in our retrospective study of around 60 plus women, we found that modulators used during pregnancy and breastfeeding didn't show any alarming safety signals, but we really do need a prospective study, and myself and Dr. Jane will be starting such a study hopefully by the end of this year. So now I'm going to turn it back over to Megan and Jillian so they can give you their perspective on what it's like to be a mom, to be pregnant, and to use modulators. So Megan, I'll turn it back over to you.
Thank you so much, Jennifer. As I mentioned, so I have not said my age, I'm 35, I have CF, and last summer I was thrilled to give birth to my son Henry, whose picture you just saw up there. And that was just over 3 years since my husband and I started trying to have a baby. So I knew from the outset, from both my primary care physician and my CF team, that due to the thicker cervical mucus that Dr. Jennifer Taylor-Cousar spoke about, that we might have a harder time conceiving, but I was supported in my journey, and my doctors believed my health was strong enough to carry a pregnancy and also to pursue fertility treatment. So in January 2017, about 7 months after we started trying on our own, my husband and I started fertility testing. So this included blood work for both of us, a semen analysis for him, a transvaginal ultrasound, and an HSG for me to check for any abnormalities or blockages in my uterine cavity and fallopian tubes. So for both of us, our results came back normal, so we ended up in that category of unexplained infertility with the hypothesis of the CF cervical mucus issue. So that led us down kind of a rabbit hole of fertility treatments that definitely took longer than we expected or hoped. So we had 6 rounds of intrauterine insemination where the cervix bypassed, and 4 of these were considered a natural cycle, so I wasn't given any extra drugs to make me ovulate. They just tracked my cycle, and then we did 2 rounds using a drug called Clomid, which helped me ovulate 1 extra egg. And on those rounds, I could detect a pregnancy hormone in my blood, but it ended up being biochemical pregnancy, so meaning the pregnancy ended before we could hear a heartbeat. So at that point, we moved on to IVF, and the first 2 rounds were at the same clinic we were at before, and we ended up having really disappointing results with that as well. We did have another biochemical pregnancy, but for the most part, we were not getting quality embryos. And so we had to get another opinion and switch clinics, and our 3rd round of IVF was kind of the magic bullet for us, and very first retrieval, very first transfer resulted in a successful pregnancy. Throughout the whole experience, I chose to stay on Orkambi, which I had started in 2015, so I had already been on it a couple years. And even though it hadn't given me a huge boost in FEV1, I really felt like my quality of life and my ability to shake off viruses was much better, and that, you know, I always told myself I could reevaluate if and when I got pregnant. So even before we started trying to conceive, we met with both a maternal fetal medicine, high-risk OBGYN, and an OBGYN who specializes in reproductive toxicology to discuss these drugs and what the options might look like. And they both assured me that even though there was no human data at the time, that from what they could read in the animal studies, that they believed it to be pretty safe for me to stay on in pregnancy and would pose minimal risk to the baby. My high-risk OBGYN especially wanted to maximize or optimize my health in pregnancy, and encouraged me to stay on my drugs. My CF team was much more cautious. They thought that my health was good enough that I could go off of a few things that they were less sure about, including Orkambi, and you know, they didn't want to put any risk on the baby. And so, you know, like I said, it was a several-year journey for us, and over time I learned of more women in the CF community getting pregnant on modulators, staying pregnant, giving birth on modulators, and with no at least immediate detriment for a lot of them. So ultimately, when I did get pregnant and I knew it was likely to be a pregnancy that would stick, I decided to stay on Orkambi. And at that point, you know, it was cold and flu season. I really felt that that taking that risk to my health of coming off the modulator was a risk that I wasn't comfortable taking, both for myself and for creating any jolt to my body that could harm the pregnancy. You know, aside from the challenges of managing blood sugars, diabetes, CFRD during pregnancy, I really remained quite healthy throughout. My lung function barely declined, and even what little I lost, I regained very quickly. I happened to come down with the flu, even though I got the flu shot midway through, and my lung function didn't come down at all. And I really attribute my ability to get over that easily to staying on a modulator. Postpartum, breastfeeding was tricky for me. Like I mentioned, I struggled with my diabetes a bit during pregnancy, and my son was born with low blood sugar, so he had to be in the NICU for a few days. So breastfeeding was more of an experience of pumping breast milk, and he was on formula from the first day too, to ensure that he was getting the calories that he needed. So I pumped and breastfed a little bit for the first month, but ultimately it was a very exhausting process for me. I lost a lot of weight really quickly, which made me nervous. And so I decided to stop after a month. And part of that decision was also related to the drugs that I was on, that I knew that when he was in utero, we really didn't have a choice, or we chose a different set of risks rather, to keep me on my drugs, and knowing that he would get some by transmission that way. But once he, you know, was out here and on his own, I felt more comfortable just continuing him on formula. So that's my general story. Certainly, while I was disappointed not to be in that first cohort of people, you know, experiencing a great surge in fertility when starting modulator, my story definitely had a happy ending. And I'm definitely happy to take any questions you have during the next session. But I'm now going to turn it over to Jillian, who's going to share her story. Sorry, Jillian, you are muted right now.
No, we still can't hear you.
We can't hear
Sorry.
you.
Nope, we're still not hearing you.
So Jen, maybe while Jillian's getting her technical issues resolved, we could ask one of the questions from the chat. One of the questions was that you mentioned that men with CF who have mutations that only cause infertility. Therefore, is it possible for men who are carriers to be infertile?
Yeah, that is possible actually, because there are, as I mentioned, are reports of men with only one CFTR mutation. So they're probably, it's one of those things where you could have multiple different things going on, but that one missing functional mutation could make you more at risk of being infertile. It doesn't mean that every man who has a carrier status is going to be infertile, but that does put you at increased risk.
One of the other highly rated questions is also about men, which is, are the tubes in men always absent or sometimes only clogged?
I think that's a great question, and it's one that hasn't been all that well studied. If you look through the literature, because it was described actually by Dr. Schwachman back in the 1960s, it was just sort of assumed, and again, because most men get tested and they don't have semen that has sperm in it, they basically think that's what the issue is. I have yet to hear of any, and this doesn't mean it can't ever happen, men go on a highly effective modulator then suddenly be able to father a child. So I think that the answer is we don't know for sure because it hasn't been looked at that closely. But right now, that's why we don't think men with CF can be fertile unless you have a mutation that confers a lot of residual function. And that's what that 1 to 2% is about.
Great. One of the questions that we received is, how do modulators impact sex drive?
No, that's another really good question. It wasn't actually reported in either of the big clinical trials. One thing that has come up that wasn't reported either was a lot of people are having more anxiety and some insomnia. And that doesn't mean everybody has it, and there may be multiple factors that contribute to that. But of course, if you had more anxiety, that may impact your sex drive through your mood, but not directly anything to do with your fertility or any other aspect. So it may impact your mood, which could then impact sex drive. I don't know, Megan, if you've heard anything else about that in chats.
I have not, no. But one of the questions that came up is seeing lots of forums and Facebook groups of women announcing pregnancies now that they're on Trikafta. And I see we have someone in that boat in this group and asking, your thoughts on staying on during the first trimester, especially.
Again, that's a really great question. I think we were very cautious in the beginning with Kalydeco and with Orkambi, as well as with Symdeko, because we just didn't know. So the animal data, again, it shows small differences if you give the moms very toxic doses, but at normal doses, it didn't show difficulties. And so when we first started having women who wanted to get pregnant on modulators ask us about that, we always said you should probably stop during your first trimester. But the more and more experience that we've seen, we have been less, I would say, adamant about that recommendation, particularly if the mom's response to the modulator was very good. So for example, I had one woman who her lung function was around 90, so she felt like it was totally safe to stop her Orkambi, but then she really had lots and lots of exacerbations, more than she'd had before she was pregnant, even before she was on Orkambi during that time. And so that's the thing that you have to weigh. And so I really think it depends on how much your response has been. And like you said, you didn't want to get sick during your pregnancy, because getting IV antibiotics also, doesn't come without risk. So I think you have to really weigh the response and how well you are feeling on the Trikafta and how many exacerbations you were having beforehand.
Thanks. Did I hear Jillian? Chime back in?
Yes, can you hear me now?
Yay.
Okay, yes. We're rolling. Thanks for problems over for a minute. All right, so I'm gonna jump into my story. I am 28 years old, and I live with my husband and our almost 4-year-old son, Simon, just outside of New Albany, Indiana. So I'm going to share a bit about our story of becoming parents, especially as it pertains to modulators. My whole life, I wanted to be a mom, but I never counted on that being my reality. My first CF team in Toledo, Ohio, knew of this dream of mine. And when my husband and I got married, my doctor gave me the okay to pursue a pregnancy. He thought my lung function and my overall health was stable enough when we were ready. At this point, I had been in the study for Kalydeco and Orkambi, both, and they gave me, like Megan, no huge jump in lung function, but my health stabilized and I was able to recover more fully when I was sick. So in August of 2015, I was just on the tail end of the Orkambi study. I was on open label, meaning I knew I was taking the drug. And that same August, much to my surprise and my husband's, we found out that we were pregnant. We were both open to pregnancy, but quite honestly, we were assuming that it would be more difficult. And we were pretty surprised. We were excited and terrified. My first CF appointment after we found out we were pregnant, we discovered that my care team had never handled a CF pregnancy before this. So they didn't have a lot of answers to our many, many questions. And because Orkambi was so new, we really didn't have answers about data there. And because I was in the end of the study, I had to stop once I became pregnant. In addition, my CF team was pretty conservative with my medicine during pregnancy, so the conversation was mostly about there's no data to make the decision, so let's minimize risks where we can to baby. So due to stopping Orkambi, my lung function did initially drop. It did rebound after some time, and my health remained relatively stable. I did have a few exacerbations that required just oral antibiotics, but I felt more junky in my lungs and had less energy. It was hard to tell what was pregnancy related and what was due to stopping Orkambi. After being, the whole pregnancy went pretty well, and I was induced 10 days early, and thankfully had a pretty non-eventful labor. Everything went well. Simon was born a healthy 6 pounds. And I also had CFRD throughout my pregnancy and before I had diabetes. So I had to work hard to manage my blood sugars throughout pregnancy. And thankfully, Simon was born with no issues because of that. And I didn't feel strongly when I was pregnant about breastfeeding, but when Simon was born, I wanted to try. I was determined, perhaps to my detriment at times, to continue as long as I could for him. Many people talk to me about the work of pregnancy, but I felt surprised after he was born how hard it was to allow my body to heal postpartum and keep up with all of my CF needs. I certainly knew this would be a big task, but physically, in those early days, you're not sleeping well. I was trying to balance treatments and care of a newborn while sustaining his nutritional needs with my own body and trying to allow it to heal. So as you can imagine, this completely wore me out. I did lose some weight, but again, held steady throughout that time. So my CF team supported my breastfeeding journey, and I stayed off of Orkambi at their advice to minimize risks. We kept Orkambi kind of as an option in our back pocket in case we needed it. And since my health was pretty stable, everything seemed okay at the time. However, when Simon was 9 months old, I was feeling especially worn down and ended up having to go on IV antibiotics. I stayed in the hospital for 1 week and then continued another week at home with IVs. And this was pretty unbearably hard for all of us. It was hard on my husband, who was home trying to convince our son to take a bottle for the first time. And it was hard on Simon, who was suddenly adjusting to life without mom. And it was really hard on me because I desperately wanted to be there with my baby and support my family. But I also knew I had to take care of my health first, so I could continue to be there for him for a long time. So this whole experience was assigned to me to restart Orkambi, to use that option that we had sort of saved for this. And after a few weeks of deliberating with my team and Simon's pediatrician, who not all of them agreed with me, and painstakingly scouring whatever research existed, I decided to continue to breastfeed while on Orkambi. And just as a precaution, we chose to check his liver levels for a couple of months, like they do on ours for modulators, and he had no issues with that. Eventually, I switched to Symdeko when it was available, and Simon weaned himself just before his 3rd birthday. So flash forward to June of 2019, Simon was getting older, and I had learned a lot about balancing my health, becoming a mom, and having a part-time job. I was feeling like I could breathe again, literally and figuratively. So due to that, my husband and I started discussing the possibility of growing our family more. During that time, I met with my new CF team, and they felt confident that if we wanted to pursue another pregnancy, we could do so. My FEV1 baseline hadn't really changed since Simon's birth, and though my weight was a little bit lower than we'd have liked, they all thought that would be manageable. I met with a new OB who asked right away if that was something that we wanted. She also supported this. And I felt so much surprise at the confidence and support from my doctors. Having one child through pregnancy was honestly beyond my dreams. So to have two kind of blew my mind. Because we anticipated the approval of Trikafta in March of 2020, thank goodness that didn't happen, we thought this might be our small window to have a baby before Trikafta was sort of another factor to decide whether to stop or start. But we weren't able to get pregnant right away. So when Trikafta was approved early last October, I, of course, was thrilled, but I was torn. I was able to get the medication, and I let this miracle drug sit in the cupboard for a couple of months while we continued to try for baby number 2. I didn't want to start the drug just to see that I would have see the benefits and then have to stop when I got pregnant. But in January, I had a virus and a drop in my lung function. And so I decided with the support of my team that the next right thing would be to start Trikafta. After I did start, my lung function jumped 20% and I had almost no cough, tons of energy, and my quality of life improved a great deal. So after discussing all of this with my OB and my CF team and many friends and family, we all agreed the benefits of Trikafta outweighed the potential risk, the potential unknown risk to the baby. We were given the go-ahead if we wanted to continue trying for baby number 2. We did, and in February we found out that we were pregnant. So I'm now 12 weeks and I'm feeling overall really great. Although there will always be unknowns when journeying through CF and pregnancy and breastfeeding, etc., I have peace knowing that we made the best decision with what information we had at the time. I'm not really able to express in this short time how painstaking parts of this process have been for us. It involved weighing so many potential risks and having so many questions that no one could answer for us, and just things that are out of our control. Questions like, should I be grateful that I have one child and still stable health? Would another pregnancy risk all of that? I prayed and I searched and I begged for many of these answers for someone to just tell us it would be okay if we decided to go for this, but of course we can never have that certainty. Simon is totally thrilled to be a big brother, and we are overjoyed at the chance to become parents to another kid. The support and confidence of my CF team and OB has made such a difference this time. But perhaps the most invaluable to me has been the village of other moms with CF who shared experiences and their wisdom have helped guide me through the difficult days. I have a handful of CF moms that I keep in touch with regularly, and a weekly group that I facilitate online. And these relationships have made all the difference. The times have changed when becoming a mom seemed like a far-off dream. Becoming a mom has made me see my body in a new light, not one of brokenness because of CF, but one of relentless strength. I thank you for allowing me to share my story, and I'm happy to answer any questions in the Q&A, which we will continue now.
Thank you, Jillian. And we'll jump back into the Q&A. Your story always makes me cry. So one of the questions from the chat is, should women with CF only attempt to get pregnant when lung function is above a certain number?
That's another really good question. And the original studies that I talked about really suggested there was a cutoff, and many of us, in spite of that registry data, still really think that below 50, it's a lot more risky for the mom and for the baby. Because women with CF have more frequent premature infants, so less than 37 weeks, even when they're healthy, and that risk is higher if your lung function is very low.
Thanks. So one question is, for a family doing IVF, should the husband stop taking Trikafta for his sperm retrieval?
Yeah, that's another really great question. And of course, because the number of men who ask that question is small, there haven't been good research studies. But what we do know is that it's going to be about 2 months that you would have to stop it because of the life cycle of the sperm when it gets stored. So you'd have to stop for 2 months before the sperm was retrieved. And again, the physician, and you have to decide whether your health is worth that risk. So if you look at the data from animals, there wasn't a big impact. There wasn't any impact on the genome. There was a little bit of decreased fertility in the animals, but again, that's opposite of what we see in people. So it's really weighing that decision about the man's health and having to be off it for 2 months versus the very small risk to the baby. And so that's a talk you have to have with your CF doctors and with your urologist.
Can you talk about the cervical mucus purge when starting a modulator? Would that be taken as an indicator of an increase in fertility for women who experience that?
You guys have awesome questions. So that actually is being studied right now by an investigator. So we definitely have heard that frequently, that all of a sudden the cervical mucus changes dramatically. So I would anecdotally be concerned if I didn't want to be pregnant that a big change in my cervical mucus might make it more likely that I would. But we don't have a study on that yet.
Slightly different question. Have there been any studies confirming the correlation between ovulation and hemoptysis?
There haven't been any studies at this point, but it is frequently reported by women. And we actually, as the Women's Health Research Group that's funded by the CF Therapeutics Development Network, are really trying to ask right now, what are the research priorities? And that one has come up quite frequently. So I know in the summertime, Dara Riva is going to be putting out a request for applications. And so if there are questions like that need to be answered, hopefully researchers will submit grants so that we can fund them and find out the answer to that question, because there hasn't been a good study.
Looks like the next question was actually for me about how did fertility treatment impact your health? And I think lung-wise, it really didn't. I feel really lucky. Like, egg retrievals 3 times. I never had an issue. The doctors were very careful with me. They were very careful not to push my ovaries into a state of dangerous hyperstimulation, which could, lead to fluid building up in the lung even for a healthy patient. So they wanted to be extra careful with me. So I really didn't have any issues there. The hardest thing, like in pregnancy, was managing my blood sugars. Having a continuous glucose monitor helped me a lot, but I didn't have it until kind of I was, the last, let's say, 6 months of my treatments, and it was really eye-opening to me how much the hormones were changing my blood sugars. And even just being on birth control for a month to get myself ready for retrievals or insemination really made my blood sugars go up a lot. And so having that tool and then having insulin was really critical, and that was not something I had in the beginning. For Jen, have you seen any changes in rates of yeast infections, UTIs, bladder issues?
So in terms of the yeast infections, I have heard women saying that they're having less yeast infections. Now, whether that's because they're getting a lot less antibiotics, because they're having less exacerbations, I'm not sure. Is it because of the change in cervical mucus? That could be another issue. But again, it's one of those areas of study, and we're so grateful that the foundation is actually recognizing that women's issues are very specific in some of these cases. And so I think all of those things will have really more clear answers in the future.
So this next question is for Jillian and myself, and I'll kick it to Jillian first. Did your husband undergo genetic testing? Was it ever scary for you to know that having a child with CF could be a risk?
Well, my husband did not. Our intention was that we would have him tested before our first son was born, but because we were surprise pregnant, that did not happen like we had planned. I wasn't really super concerned because I knew there was no history in his family and that the chances would be, pretty small, but our son was not born with CF, and then after his birth, we did have my husband tested, and he's not a carrier. How about you, Megan?
Yeah, so we had to, the reproductive endocrinologists we work with felt very strongly that we be tested. I think they didn't want to, knowingly get us into a situation that would be hard. He was not a carrier, my husband was not a carrier, so it was never an issue, but, when we were starting to do the testing, it did weigh on me of, not that I felt like I wouldn't be capable of caring for a child with CF. I feel like an adult with CF probably is the most capable of that, but fearful that the bacteria growing in my lungs could hurt my baby before he would even have a chance to, have healthy lungs was something that I wasn't sure I could handle. So
and can I just weigh in from the doctor perspective? At National Jewish, we actually really do push our women who are thinking about pregnancy to get their husband tested or their partner, because we have had cases, one case where they didn't get tested, and then they found out surprisingly that even though the risk was low, that the baby did have CF, and because his mutation was a severe mutation, the baby is actually much sicker than the mom was when she was a child. So that's been really, really difficult. And there was another case where the partner was Hispanic, and so they thought, well, it's probably a really low risk, but we'll do it just in case. And it turned out he actually did have a mutation, even though the rate in people of Hispanic origin is much lower, he still was a carrier. So we really do, at least so you can make informed decisions. Of course, every woman has to decide for herself.
Yeah, thank you. Yeah, my CF team also encouraged the testing too. So one question is, after years of heavy coughing, I now have a weakened pelvic floor. Does Trikafta help reduce coughing and therefore help the pelvic floor not to be strained as much?
Seriously, you guys need to go to medical school. It feels like you already have because you're asking good questions. So we don't know the answer. I do think that people cough a lot less. I've heard that said to me over and over by almost every single person that has started Trikafta. Whether or not you can rebuild those muscles, there are OBGYNs who specialize in pelvic floor disorders, and you can do things like Kegel exercises. So I don't think Trikafta would have a direct effect on those muscles, although perhaps you can build muscle better when you're able to absorb more calories and more protein and fat. But yeah, I think that's one thing that for sure hasn't been studied, but I do think that the coughing will be less, and so you have a better chance of trying to rebuild those muscles because you're not putting as much strain on them every day.
The next question is, are there any online groups for CF dads? And also, are there any clinical studies focused on fertility in men with CF to participate in? So maybe the first part goes to Jillian, second part to Jen. Do you know?
I do not know. Yeah, I don't know of any CF dad groups. There were no CF mom groups when I started this one, which is why I started it, because I saw a need for it. So I say if you see a need, Attain Health is the group that I partner with to facilitate this group. I'm sure they'd be open to running a group for dads because that's definitely needed in the community.
Yeah, I second that statement because I have had men say I wasn't really thinking about in vitro because I didn't think I was healthy enough to help my wife take care of a child, but now that I'm on Trikafta, I do think that. So I think a men's group would be great if someone wanted to start it. And the second part of the question was what again, Megan?
Are there any clinical studies focused on fertility in men with CF that he can participate in?
That's a great question. There aren't yet, but there is actually, because of the Women's Health Group, this has come up more often. And I actually know that there's a group who's starting to look at questions in men's health, but we're starting really from almost scratch in men's health because it just hasn't been brought up very much before now. I mean, this is one of the first times that publicly we've been able to have a conversation about sex actually on one of these conferences. So I think that it will happen in the near future. We just have to have more people bring it up. And so again, that they can send out research grant offers for things like fertility in men.
Do we know anything about miscarriage and stopping modulators during early pregnancy?
So from the data that we collected, the miscarriage rate was actually lower than the general rate. So we don't think that modulators cause miscarriage, at least in the data that we've seen so far. And again, we'll study that in our prospective study. Whether or not stopping it and then getting sick would cause a miscarriage, that answer is completely unknown.
Mm-hmm. So following up on the answer about yeast infections is a question about urinary tract issues. Are we seeing anything there?
I have not seen any reports in the literature, nor have I actually heard of any women talking about the impact on bladder infections. Anything in the chat groups about that? Either of you?
I have not seen anything. More on the yeast infection issue. So to confirm, hormonal contraception like a pill or an IUD with hormones is now okay to take if on Trikafta, unlike on Orkambi.
Correct. So even with and this is off label, I'll say that right now. So the Mirena IUD was one that does have hormones in it, obviously. We have a lot of women who use that even on Orkambi because the action of an IUD isn't through the hormones because it's just local. And so the Mirena IUD we used in a lot of people, but with Trikafta it doesn't matter. You can use the pill, you can use Depo, you can use whatever you want.
And the last question, because we'll need to wrap up, is that my OBGYN said that CF makes it hard for those of us with small frames to retain estrogen. Have modulators had any impact on retaining hormones?
That definitely hasn't been looked at yet, but we are going to be asking that question as part of our prospective study. We're hoping to not only look at the pharmacogenetics and so basically how well the modulators are working and what levels they have in women with CF who are pregnant and on their modulator. But we also want to look at hormones during that study because we don't know the answer to that question.
All right. Thank you so much, Jillian and Jennifer, for speaking with us today. Thanks, everyone, for watching and participating and for your excellent questions. I'm sure this could go on for a very long time if we would let it. There will be resources, including Jennifer's slides, in the resource room where you'll be able to download what we saw today. And we'll now have a 15-minute break before our next round of info sessions. So thank you all so much. And we can close out of this window and return to the main environment. Have a great night.
Good night, everybody.
Thank you all.